Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Welcome into the another episode of our case histories discussion on gut-brain axis. Today is the fifth and last case history of the series. Till now, we have discussed the IBS patient, the patient with functional dyspepsia, patient with post-infectious IBS, then patient with functional constipation. Today, we shall discuss the case history of a patient with functional heartburn. And this is, I call it NERD versus functional esophageal disorders. So this is a case history of 40-year-old male who presents with chronic heartburn, regurgitation, and throat discomfort. Endoscopy and pH monitoring has been done and they are reported to be normal. PPIs provided only minimal relief. So, 40 years old male with chronic heartburn, regurgitation, throat discomfort, that is the GERD-like dyspepsia, where endoscopy, pH monitoring normal, and PPI were tried and they give only minimal relief. So, question comes in mind, what's driving his symptoms? He's got no esophagitis, he's got no pathology, his pH manometry is normal, PPIs have been given, and they have not relieved his symptoms. So why his symptoms are still there? So the contributing mechanisms or thoughts or factor is not all reflux symptoms are good. Remember, not all reflux symptoms are because of the GERD or gastroesophageal reflux disease. And second, the gut-brain interaction in functional heartburn is very much reality. So, just to elaborate on this first part, not all reflux symptoms are GERD. The non-erosive reflux disease, NERD versus functional heartburn, we know this, that it's both the existing and both have got their own ways of presentation. Esophageal hypersensitivity and altered vagal perception are key in such cases when there's functional heartburn. And when we study, we see the esophageal hypersensitivity and altered vagal perception. And few words about the gut-brain interaction. Stress, anxiety, and central pain, it amplifies the condition, and its amplification play a major role. Then PPIs won't work if the issue is hypersensitivity rather than acid. And these are the reason over here. So, what should be the management approach for such patient? Diet and lifestyle adjustment, the one component of the management approach. The neuromodulators instead of PPIs, and psychological interventions. So let's few words about the diet and lifestyle adjustment as a management approach to the patient with functional heartburn. Avoid late night meals and aerophagia, excessive air swallowing. So this is very important and it should be done at the conscious level. Then consider gabapentin or pregabalin for neuropathic pain if it is severe. Then the another component, the neuromodulators, instead of PPIs, low-dose tricyclic antidepressants, nortriptyline or amitriptyline, they reduce esophageal pain perception and they should be tried. Then buspirone, it improves esophageal motility and relaxation. Then the psychological intervention, these are very, very important. CBT and gut-directed hypnotherapy shown to improve esophageal pain perception. So the key message from the case history on functional heartburn is that not all heartburn is acid-related. Not all heartburn is acid-related. Functional esophageal disorders need a gut-brain approach. So just to recall our key takeaways from these case histories, the functional GI disorders are the DGBIs or rare, not psychosomatic. The gut-brain axis dysfunction leads to visceral hypersensitivity, dysmotility, and dysbiosis. The diagnosis is clinical, and according to the Rome 4 criteria, diagnosis should be made, and so avoid unnecessary tests unless red flags are present. And multimodal treatment works best. Dietary therapy, psychological interventions, and targeted pharmacological therapy. These are the three main components of multimodal treatment. And remember, the future is microbiome-based therapies, which includes postbiotics and fecal microbiota transplants. Then gut-specific neuromodulators, which are the serotonergic agents targeting the ENS. Dear viewers, we have come to the end of our discussion of the case histories, but let's continue the conversation. What's your biggest challenge in managing IBS and functional dyspepsia patients? Please share your experience in the comments section below. And with this, I pay thanks to you for being with me during these case histories discussion. I hope with the help of these case histories, it will be clear in your mind that when there is normal endoscopies, normal colonoscopies, normal other related tests, and the patient is still symptomatic, do not forget it may be a disorder of the gut-brain interaction, and it should be approached in that way, and multimodal therapy works here. So we end here. Inshallah, see you in another course of the gastroenterology topic. Till then, take care. Khuda Hafiz.